Hello, everybody. I'd like to thank ISET for giving me this opportunity to present my paper in this national forum, and also to my entire ECMO team who have allowed me to present them. So, from the beginning of the 2020, we have seen that the COVID-19 virus spread all over the country very rapidly, and the severely ill patients suffer from pneumonia and ARDS. And to treat these patients, we have to put them on ECMO. But this ECMO is different from that of regular ECMO that we have done before. All the resources and techniques utilized before the initiation of ECMO. ECMO is done in cohort place that is not in regular ECMO ICU. Staff safety is very important in these cases. Remote monitoring via camera and EICU help us to monitor the patient from distant and on a regular basis and take good care of them. Handling the membrane is one of the most important thing that we have to taken care of. As this patient have the role relative, as this patient the relative cannot come close to the patient to see them, we have to communicate with the patient on regular basis, and for any type of consent we have to take them via email and mm, get give update of the patient condition via phone calls and video calls. So these are the new things that we have done in this situation. So this is our ECMO team that worked day and night for long 9 months to fight against COVID-19 and faces challenges and welcome them together. So initially with the PPE, we have suffered a lot. The uncomfortableness of PPE and proper visualization via the goggles and visor was not there. Getting exhausted easily inside the airtight jacket is was very common. Unable to hear properly via through this PPE, and we have to talk very louder. Less helping hand inside the COVID ICU. So an exchange of messages inside and outside is very difficult. So initially we have two ECMO that give support to the two patients, but with the increase in number of infection, we have to increase the number of ECMO machines, and as a result, one time there was 14 machines running together. So these are the machines that we have used during this time, but with the increase of the infection and machines, the manpower does not increase. So our ECMO team has supported and given their 100% to overcome this issue. And with that all, we have with that all with demand increases, demand of the disposables also increases. But the supply chain broken due to lockdown and infection increase day by day. So we have to make balance between supply and use. So this is a challenge that we have faced, and we have improvised in this situation something new, that we have assembled and primed the circuit inside outside, and handed over to the inside person, so that inside person have to work less. We have used indicator based 3-pin plug to identify if any power fault is there or not. As the place of ECMO therapy is not our regular ECMO ICU, so there is less number of air and oxygen port. So we have bifurcated the line to supply the ECMO machine and ventilator at the same time. Use of hemotherm is also a challenging thing, because there is less number of ECMO hemotherm. We have used the OT hemotherm and bifurcated them, the lines, into 2 and 3 to supply more than 2 machines. Initially we have less number of blenders, but we have managed by arranging local made flow meters. So frequent signal alarm is one of the common problem in the ECMO machine, that gives due to the dryness of the jelly in the pump head. So we have used Nevia cream that increases the time limit more than 48 hours. We have improvised cameras inside the COVID ICU for each and every patient, so that we distantly monitor the patient from home and take down the data that of the patient, and update them in the Google Sheet so that we can manage them from anywhere, anytime we want. The cam we set up are accessible from via mobile, and anyone can see and everyone can see the patient condition, patient situation, patient movement, and every time. The WhatsApp group also help us to communicate it with the patient and patient nursing staff and doctors at the same time. After initiation of the ECMO, the thrombosis and prolonged thrombosis is one of the most thing that we have faced. Prolonged courses of ECMO. This because this ECMO is not regular like that of regular ECMO that we have done before. This is a prolonged course. This is a slow process, and this progress is very slow. Cytokine storm was there, and multi-organ failure, early multi-organ failure was seen. So first challenges we have faced on ground transport, because the PPE we wear outside the hospital environment is really painful, and in the hot and humid condition outside. Transporting the patient via air ambulance in that very small place is also very challenging. Pneumonia with myocarditis. In this patient, you can see that the enlarged LA and atrium and ventricle. With the increase of that, we have to put the patient on VAV. So 2 or 3 patients are we have put on VAV ECMO, and and we have to increase the anaerobic support also. And cytokine storm is seen on the patient, and this is one of the cases that cytokines that suffers from cytokine storm. We have used cytosoft to overcome this challenge. Obese patient have to take care, especially because they cannot be turned easily. So we have to need more manpower, and the patient, we cannot prone them easily. So this is one of the challenges that we face. But these patients are get well and came out of ECMO very fast. We have seen that in our 4 to 5, 5 to 6 cases we have found. We have obese patient. There are obese patient, and we have managed to get well, and patient go home. Refractory hypoxia in PV ECMO is very common, and we have, in despite of maximum flow, the patient does not maintain saturation, and we have to make bone on ECMO, and that give us good result. And but this proning and mobilization needs special care, because the patient is tracheostomized, and we have to take care of the tracheostomy site. Kinking of cannula and line may be there, so we have to take care of that. And dislodgement, there is chance of dislodgement of the cannula is also there. So this is our statistic. Then I have done 59 cases till now, and the 34 cases are maximum are femoral-jugular, 25 are femoral, and 23 transported by ground, and 2 patients are via air ambulance, and 22 went home. 1 patient and still on mechanical ventilation after decannulation, and 4 on ECMO. So this is very time consuming game, and this is we can call it a marathon. It needs more time. So more time, with the more time and with slow result, really demotivating. And as a patient, with 2 or 3 patients are getting well and going home, in between that 3 to 4 patients are dying. So this is somewhat demotivating, and our seniors and doctors help us a lot to remotivate us and to make the work easy for us. So this is a teamwork that have need very much dedication, and for every team personals, and everyone work hard to get some smiling faces, and this is still going on. The journey is still there. So this is all about our journey and challenges we faced. Thank you.